morning. My name is Francesca Gai and I work in the University of Torino in Italy. I presented at ASCO the results of the sustMRD negativity in patients with newly diagnosed myeloma treated with carfilzomib, lenalidomide and dexamethasone with or without isatuximab. The results of the phase III IsKia trial. The trial was conducted in Europe in 42 active sites and enrolled 302 newly diagnosed myeloma patients eligible for high-dose chemo transplant. Patients received carfilzomib, lenalidomide, dexamethasone full-dose induction, transplant, autologous transplant, then 4 cycles of carfilzomib, lenalidomide and dexamethasone consolidation, same schema as induction, and then a prolonged treatment with light consolidation of reduced intensity carfilzomib, lenalidomide and dexamethasone. In the experimental arm, patients receive exactly the same therapy, but with isatuximab. We focused in this presentation on the data referring to the light consolidation phase as the data for the induction and post-transplant full-dose consolidation were already presented. So the main objectives were to evaluate the rate of 1 year sustMRD negativity in the 2 arms and to focus on different risk groups, particularly high risk, and also to look at the safety of the light consolidation phase, particularly the rate of adverse events and discontinuation due to toxicities. So the light consolidation was started by 126 patients in the IsaKRd arm and 136 in the KRd arm. A similar proportion of patients completed the treatment, with 9% and 70% of these patients who discontinued, 3% and 2% of them that discontinued for adverse events. So at the starting point of our current analysis, that was the post-transplant full-dose consolidation, we had a significantly percentage of patients who had achieved an MRD negativity at the 10 to minus 6 threshold with IsaKRd versus KRd, 68% versus 48%. The MRD negativity, particularly at the 10 to minus 6, increased during the light consolidation phase, with 74% of patients that were MRD negative at the post-light consolidation time point in IsaKRd versus 64% with KRd. The overall treatment translated into a significantly higher proportion of patients that achieved a 10 to minus 6 1 year sustMRD negativity with IsaKRd 52% versus 38%. And the benefit was seen in all groups of patients, including high-risk patients. And looking at different high-risk groups, the proportion of patients who had 10 to minus 6 1 year sustMRD negativity was similar in the IsaKRd arm, while it was definitely lower in high risk, particularly very high risk patients with KRd. We looked also at the rate of functional high risk, meaning the rate of patients who progressed within 18 months from the starting of the therapy, and the rate was low, 3% and 4% in both arms, suggesting the effectiveness of carfilzomib in this setting. Toxicity was similar in the 2 arms. The main adverse events were hematologic, particularly neutropenia of grade 3-4, 18 and 17% of patients. All other non-hematologic toxicities were less frequent, the most frequent being infections. So we can conclude that isatuximab KRd significantly increased the rate of 10 to minus 6 1 year sustMRD negativity. This was seen also in patients with high risk and very high risk disease. And we all know the importance of achieving and maintaining MRD negativity in terms of improving the prognosis for our patients. The rate of early relapse was low in both arms, meaning that the second generation PI carfilzomib is effective in this setting. Treatment was tolerable with no increased toxicity with IsaKRd compared with KRd. We also analyzed different MRD thresholds, and we see that in these context of this highly effective therapy, the 10 to minus 6 MRD negativity cutoff is more informative than the 10 to minus 5. I'd like to thank all the patients, nurses, and physicians that participated in the trial and all our collaborators throughout Europe.